This conference will now be recorded. This conference will now be recorded.
Yeah, tell me. So, I think you people will not answer or something. So, routinely we use only one drug. Not only one drug, routinely used drug. One of the drug is paracetamol. That is also called as acetaminophen. Paracetamol, it is most commonly used drug in pediatrics for fever, for pains and everything. Comparatively, one of the safest drug out of all the non-steroidal anti-inflammatory drugs. So, you should know what is the dose we'll give in either per oral or intravascular or intramuscular, but preferable route that we usually administer is per oral. The dose you have to know. The dose is, see, for any pediatric thing, you have to know the dose per kg per day or per kg per dose you should know, because that is not the same thing like adults. For suppose we adults will take the drug paracetamol either 500 mg or 650 mg irrespective, like you will take the same thing, I'll take the same thing, there is no difference. But that is not with the pediatrics. We have to go with the doses, we have to go with the weight, we have to go with the age and all these things. Usually we go with our weight, so per kg per day one should know. So the most commonly used is paracetamol. It is also called as acetaminophen. The dose is 15 mg per kg per dose. We give every 6th hourly, that is 4 times a day. So maximum, for suppose, so we are telling it is 15 mg per kg per dose. So total, the drug should not exceed more than 60 mg per kg per day, 6th hourly. So for suppose if the child is weighing for suppose 100 kilograms, so you cannot go on giving the dose or you cannot go on dumping. The cut should be there for even for a maximum dose, that is 60 mg per kg per day. Side effects, some side effects will be there for every drug. It's like sometimes you may observe nausea or vomiting, but rarely, very rare, but you can come across. Sometimes mild skin reactions or skin rashes can also be there. Usually with your over toxicity of this paracetamol drug causes acute hepatic failure. So acute hepatic failure is one of the deadliest complication with your paracetamol when taken in high doses, that is when crossing the dose of around 90 mg per kg per day. The maximum is 60 mg per kg per day is allowed. If you take the drug of 90 mg per kg per day, then you get this side effect of acute liver failure or acute liver toxicity. The antidote for this is N-acetylcysteine. So this is the basic drug, paracetamol. And you have to know what are the other anti-inflammatory drugs apart from this, that is your ibuprofen and indomethacin, mefenamic acid. These three drugs are also we are using. Out of this mefenamic acid, the dose is 9.5, that is around roughly 10 to 25 mg per kg per day. And usually mefenamic acid we can not continue for more than 7 days. The side effects of this mefenamic acid is rashes, gastrointestinal disturbances like vomiting or nausea, thrombocytopenias, aplastic anemias and hemolytic anemias can also come across, but this is the rare entity. And one more drug is indomethacin and ibuprofen. Indomethacin, same, both are NSAIDs only, but you have to remember what is the potential use of indomethacin along with your anti-inflammatory and analgesic and antipyretic effects. It is used for the closure of patent ductus arteriosus in a preterm babies. That you have to know. The side effect for this indomethacin is renal insufficiencies, thrombocytopenia, bleeding manifestations, intraventricular hemorrhage. So I repeat again the 4 complications: renal insufficiency, thrombocytopenia, bleeding diathesis, like thrombocytopenia, obviously expect bleeding, right? Intraventricular hemorrhages and necrotizing enterocolitis. These are the basic NSAIDs. You people must know regarding paracetamol. The dose is 15 mg per kg per dose 6th hourly. So we give a total of 60 mg per kg per day in a 4 divided doses, that is QID interval. So these are all the commonly asked drugs, like anything they may ask, but what are the things we keep in your examination table is all these things will come into it. The thing is sodium bicarbonate. So you most probably asked questions are, what are all the strengths available? What are the clinical indications of IV sodium bicarbonate? How to administer this drug? So these are the potential things what they can ask. So what are the available strengths? The answer there, it is like 7.5% strength one it is available, or the strength available is again one more strength is 8.4% weight by volume, where we use this sodium bicarbonate. So this is an alkali, right? So in severe metabolic acidosis, we use this. What are the clinical conditions you get severe metabolic acidosis is, like you all know, diabetic ketoacidosis, inborn errors of metabolism, poisonings like salicylate poisoning, aspirin poisoning, all these things you get severe metabolic acidosis. And one more thing, what are the what is the difficulty, or what is the probable potential side effect of giving this sodium bicarbonate also one should know. Because see, in severe metabolic acidosis what is going to happen is like your H plus ions, that is your acidemia will be there. So H plus ions will be like rampant in your thing in your body. So when you give injudiciously this sodium bicarbonate, what will happen? Bicarbonate is HCO3, right? So your acid is H plus. When they combine, what is the reaction that is going to happen is they'll form H2O plus CO2. So water, there is nothing harm with water. For suppose carbon dioxide is there, it is a cerebral vasodilator. So increased cerebral blood flow will be there. And so in preterms and in also in patients having cerebral edema, more potential to have devastating complications of cerebral edemas as well as intraventricular hemorrhages. These are the one of the potential complications that you come across with your sodium bicarbonate. Obviously, for every drug there will be an indication and also the potential side effect one can expect, right? So how to administer? Never ever administer like a bolus. So you have to mix it with either sterile water, that is your distilled water, or with your normal saline, and administer slowly over 1 hour. And dose is like 1 milliequivalent per kg per minute. So see, 7.5% strength, like 1 cc 7.5%, usually in 1 ml it contains 0.9 milliequivalents. So we roughly take it as 6 milliequivalents. What are the other indications where will you use this sodium bicarbonate? Usually sometimes during exchange transfusion we may use in neonates also, apart from these indications like acidosis, inborn errors of metabolism, salicylate poison. And also what are the other conditions we use this sodium bicarbonate is important thing for to management of hyperkalemia, tetralogy of Fallot with cyanotic spell. What happens in your hyperkalemia? In your hyperkalemia we expect metabolic acidosis. So when you're going to give this bicarbonate, what happens is your shift of potassium to cells. So intracellular shift will happen, so that we're reducing your potassium levels. So hyperkalemia will be reduced when you give this sodium bicarbonate. And also, what are the other conditions you expect metabolic acidosis is in case of renal tubular acidosis, where we use distal renal tubular acidosis, lots and lots of bicarbonate will be lost in your urine. So we give the dose of bicarbonate around 20 milliequivalent per kg per day. So that solution we call it as nodosis, where we supplement bicarbonates. That is in one more case, that is your distal tubular acidosis. So roughly in severe metabolic acidosis, in salicylate poisoning, in tetralogy of Fallot with your cyanotic spell, where severe metabolic acidosis will be there. There also we give bicarbonate in your hyperkalemia and also in your distal tubular acidosis. These are all the indications we give. I already told you one of the side effects is intraventricular hemorrhage or cerebral edema in a premature children. And what are the other probable side effects you have to know? That is, see, sodium bicarbonate. So along with your bicarbonate, what we are dumping is your sodium. So sodium overload also will happen. So this is one of the potential side effect. And also, for suppose if you are giving this through umbilical vein, the if at all umbilical catheter is not in a proper position, it will damage even your liver. So liver damage may occur if given through your umbilical vein. Even it causes hypocalcemia. So obviously it aggravates your tetany. So these are all the indications as well as few side effects of sodium bicarbonate. I hope I am clear. So mostly asked questions, what are the strengths, what are the indications, how to dilute, and what are the side effects. So this is all regarding your sodium bicarbonate. Next your thing is, next drug that is a potential question for your VIVA. See, this is a practical class, only VIVA table drugs randomly we are discussing. These are all like your IP teaching slides. So most probably these are the things that will be there in your examination even. So calcium gluconate. So the probable questions that you may come across are, what are the clinical indications of IV calcium gluconate? What precautions should be taken while giving IV? And also rest of the questions I'll be discussing. So calcium gluconate, same like sodium bicarbonate, you have to know what are the available preparations. See, they'll give you a drug to your hand itself. So if you don't know, try to see very smartly and try to answer what is there on your vial or your ampule, right? So available preparations we usually keep it in your examination is calcium gluconate that contains 9% of calcium. So 9%. So it contains 9 milligrams of calcium, of elemental calcium. So there also 1 ml contains 1 milliequivalent of calcium. See, this is purely your IV preparation. So what are the indications where we give IV calcium, not oral calcium, IV, that is symptomatic hypocalcemia. What are the symptoms that we expect in a hypocalcemia? That is your tetany and seizures. And what is the other indication you give your calcium apart from your symptomatic hypocalcemia is hyperkalemia. What happens with this hyperkalemia? I already told you, for hyperkalemia, the only treatment we have to send your calcium from extracellular thing to intravascular thing, so to decrease your potassium levels. There is no role of calcium in that point. Only calcium helps to protect the heart from arrhythmogenicity of potassium. See, that is like a stabilization of your cell membrane. That's why we are giving calcium in hyperkalemia. It does not decrease your potassium levels. Calcium helps in stabilizing your electrical potential or this membrane potential. So it protects the heart from arrhythmogenicity. That is potential to get arrhythmias due to potassium. That is one of the thing. There in that condition also you preferably give IV calcium. So symptomatic hypocalcemia and even hyperkalemia we give your IV calcium. And also what are the other indications means during exchange transfusion also we expect a complication of hypocalcemia. In that condition also we give your IV calcium gluconate. So what are the possible side effects one can see with this drug? See, it is a vesicant drug, so patency of IV line should be verified before giving it, or else what will happen? If extravasation of this solution occurs, it causes necrosis of subcutaneous tissue. So the subcutaneous necrosis will happen, resulting in devastating complications. And also, it should be given very slowly, only after dilution with your normal saline or 5% dextrose. Under strictly cardiac monitoring, because infusion can cause bradycardia of less than 60 per minute. And what are the other things? Same thing, if at all if you are giving with your umbilical line, if the line is not in a proper position, if at all it is there in your liver parenchyma, So hepatic necrosis will occur, so resulting in hepatic damage. So these are all the side effects for this, like one is your subcutaneous necrosis, one is your like it is potential to cause bradycardia, and one more thing is your hepatic damage or hepatic necrosis if not line is in proper position. And what are the indications? Indications are symptomatic hypocalcemia, hyperkalemia, and during your exchange transfusion. Available strengths are 9% calcium, that is calcium gluconate containing 9% of calcium. These are all your strengths. So till now we discussed 3 drugs. One is your paracetamol, another one is your sodium bicarbonate, next is your calcium gluconate. Next drug is your solution injection dextrose. What are the clinical indications? What are the concentrations available and up to what concentration we can give through a peripheral line? This is the expected question. Dextrose. You see dextrose will be available in different strengths that like each supplies 10% can be there, 5% will be there, 25%, 12.5%. All these things can be there. So 5% dextrose means 5 grams in 100 ml. That is what you have to know. But why we are insisting on your strengths means you can give strength of only 12.5% through your peripheral line. Beyond that, you have to use your central line. So what are the uses where we use your dextrose? In hypoglycemias, in hypoglycemia in neonates, acute symptomatic hypoglycemia, the dose we give is 2 ml per kg of 10% dextrose as a bolus. If at all it is an older children, we give 10% dextrose of 2 to 4 ml per kg. And also in older children, for suppose treatment of hypoglycemia due to your insulin therapies, also we give your glucose. What are the side effects? If at all any extravasation occurs through your line, it can cause thrombophlebitis. And also highly concentrated solutions in a premature babies if you give, leading to your cerebral edema and also intraventricular hemorrhage. What is phenytoin? Someone answer. What is this drug called injection phenytoin sodium? For what condition we use this?
Antiepileptics.
Yeah, very good. It is an anti-epileptic drug. So the same thing. So these are the questions. What are the clinical uses of phenytoin? How do you administer IV phenytoin? What are the serious side effects if administered rapidly? And what are the 2 important side effects following long-term use of phenytoin which can be prevented? See, these are the expected questions only. These are not only questions. So phenytoin, it can be available in either of the form like tablets, syrups or injection. But we are going to discuss IV, that is injection phenytoin. Phenytoin usually comes in an vial of, ampule of 2 ml. Each ml contains 50 mg. So it decreases threshold of seizures. Sorry, it increases threshold of seizures, so by prevention of seizures. So it is an anticonvulsant. Especially it is used in status epilepticus beyond neonatal age group. The dosage is, the loading dose of phenytoin is 20 mg per kg per day, followed by your maintenance dose of 5 to 8 mg per kg per day. Whenever you are diluting and whenever you are giving your drug, the rate should not exceed 1 mg per kg per minute. Usually blood concentration levels, therapeutic level is 10 to 20 microgram per ml. So where we use this phenytoin, one is already you people told, one is in your seizure thing, and also maybe you may or may not remember, I don't know exactly, it is also one of the drug column that is you can see in your antiarrhythmic drugs. One has its classification, you see in your antiarrhythmic drug also phenytoin will be there. So it is usually used to treat even digoxin toxicity. That is one of the other use of this phenytoin apart from your epilepsy. And also it is used in treatment of trigeminal neuralgias, and it also used in myotonia congenita condition. So these are the 4 expected conditions where we use your phenytoin. And what are the possible side effects of this phenytoin? One is your hirsutism, gum hypertrophies, folic acid deficiencies, rickets. So because of hypocalcemia, that's why whenever we are putting this phenytoin drug, we usually supplement with your calcium and along with your vitamin D. And we expect some skin rashes like Steven-Johnson syndrome and allergic rashes and pseudolymphoma syndrome. This is all few points about your phenytoin. So phenytoin is an anticonvulsant. The dosage is loading dose of 20 mg per kg per day, followed by maintenance of 5 to 8 mg per kg per day. And it is also used to treat even digoxin toxicity, trigeminal neuralgias, myotonia congenita. And the side effects are hirsutism, gum hypertrophies, rickets, folic acid deficiencies, some skin rashes like Steven-Johnson syndrome, and even allergic reactions. So these are the probable side effects. So next is your Phenobarbitone. This is also your antiepileptic drug. Usually, these are the questions. What is the clinical use? What clinical parameters to be monitored while giving this medicine intravenously? Is there any other clinical use for the same oral medicine? These are all the things, questions. So this is an anticonvulsant. Usually, how does it act? It inhibits GABA reductase, so it increases the concentration of GABA amino benzoic acid. So the GABA levels will be increased. It also decreases the post-tetanic potentiation, and also it inhibits the reticular activating system. So what is all happening? So comparatively, this is like a more of a sedative action, and also it reduces seizure potential even. So it is an antiepileptic. We use this antiepileptic mostly in neonates, and it is a drug we give initially with the child with neonatal status epilepticus. So the dose is 15 mg per kg per day, followed by your maintenance dose of 3 to 5 mg per kg per day. What are the other uses along with your convulsions? That is hyperbilirubinemia. Why? This is an enzyme inducer. It can increase the excretion of bilirubin by increasing liver metabolism. So it is used in neonatal jaundice as well as in some cholestatic liver disorders like neonatal hepatitis syndrome. Simply you remember what are all the other uses of this phenobarbital. Phenobarbitone antiepileptic is also a potential enzyme inducer, so it is used in treatment of your hyperbilirubinemia. This is enough. When older children, apart from this, we can even use in some simple febrile convulsions and even dramatic chorea. So what are the things you have to monitor when giving this drug? You have to monitor respiration because it is potential to cause respiratory depression while giving IV. So side effects are drowsiness, irritability, minimum brain dysfunction. Prolonged use can cause disturbance in cognitive function. Skin, sometimes it can cause rash, Steven-Johnson syndromes, and porphyrias. Next is your adrenaline. What is adrenaline?
Sympathomimetic drug.
Amma వినిపించలేదు నాన్న.
Sympathomimetic, ma'am.
Yeah. What is sympathomimetic drug? Simply what we call it as? We call it as an inotrope, right?
Inotrope.
Yeah, very good. So these are the questions, like what are its clinical uses? What are the dosages? And what are the possible routes of administration? So someone tell me, what are the possible routes of administration of adrenaline? Just okay, చెప్పండి. What are the possible administered doses, routes of your adrenaline? Can you give it in oral? No. You can give either subcutaneously or intramuscularly
IV or
or
subcutaneous.
yeah, even IM. So these are all the possible things. Okay. So what are all the things we can use this adrenaline? Apart from your inotropic effect, like inotropes, cardiac contractility will be more in shock conditions, like in hypovolemic shock, even in in cold septic shocks, all these conditions, the name itself it is indicating, so you can answer very rapidly in a shock news. And also the specific indication is your anaphylactic shock. So that is another entity. One more thing, in your resuscitation, when cardiac arrest happens, so in your resuscitation and cardiac arrest also you give this adrenaline. One more thing, so out of box means you may not remember that only possible thing, that is your bronchial asthma. Even in status asthmaticus, the role of adrenaline will be there. There we give subcutaneously almost 3 doses of adrenaline. So that is one of your other indication you have to remember. So coming to your doses. So usually adrenaline comes in your vial of 1 ml. So 1 ml contains 1 mg of adrenaline. So usually for suppose cardiac arrest, we will dilute. What will we do is 1 ml contains 1 mg. Usually we dilute 1 ml of adrenaline. What is there in that ampule, will break it and will dilute with 9 ml. So at that point of time, so 10 ml contains 1 mg. So 1 ml contains 0.01 mg. So in cardiac arrest, we have to take the diluted drug. Out of that dilution, you have to take 0.1 ml per kg per dose. For that dose, we can use either IV or sometimes for suppose we can use even endotracheal route also. So those are all the things how to dilute, how to administer. So whenever you are giving it through IV, the dose is diluted in 1 in 10 dilution. Intratracheally undiluted, you can give it directly. So these are all the things. Another one more thing is your croup, that is acute laryngotracheobronchitis. There also you give your adrenaline. So the doses of less than 6 months 2.5 ml, more than 6 months 5 ml undiluted adrenaline. Here the mode of administration is your nebulization form. So remaining all the things you know, that being in anaphylactic shock we give through intramuscular route, and in your cardiac arrest we give intravascular route, or undiluted form we can give it in endotracheal route. In croup we give through nebulization form, but in status asthmaticus we give either again through subcutaneous. So what are the possible side effects for this drug of adrenaline? We can expect tremors, palpitations, arrhythmias, and sudden rebound hypertensions. So these are the possible questions that may ask in your VIVA. Next drug is your potassium chloride. What is potassium chloride? So nothing but potassium. So we give this drug in hypokalemias, right? So what are the clinical situations in which a patient may get hypokalemia? What is the danger of IV potassium chloride? These are the potential questions you can get. So severe vomiting, diarrhea, continuous nasogastric aspirations during treatment of diabetic ketoacidosis. So these are all the conditions you get your hypokalemia. See, remaining all are obvious. Through vomiting, the loss will be there. Diarrhea, loss will be there. So these are all the things that you may know why potassium is losing, because you can see obvious loss. Then why during treatment of diabetic ketoacidosis, you may get doubt. What happens in your diabetic ketoacidosis? Usually acidosis. Acidosis, what will happen? The shift will be out. Initially, hyperkalemia will be there. So in diabetic acidosis, you get hyperkalemia. But during treatment of diabetic acidosis, I already discussed one drug called as bicarbonate, or remaining all the things. When you are treating your acidosis, what happens is, so you are coming down those acidic environment to alkali environment. So automatically the shift of potassium there from the cell, from vascular component to your cells. So automatically during your treatment, potassium levels will come down. So at that point of time, during your treatment, you expect hypokalemias. So we will add potassium to your fluids. So when you are giving your fluids of either 10% dextrose or 5% dextrose along with your normal saline, add your potassium. Usually potassium chloride, it contains 1 ml contains 2 milliequivalents. So usually it comes in vial of 10 ml. So 10 ml contains 20 milliequivalents. So one can add to a 1 liter of NS or any other fluid to a maximum of 40 milliequivalents per liter. So 40 milliequivalents. So maximum dose is 40 milliequivalents per liter. So these are all the indications where we give IV potassium, not during diabetic ketoacidosis. During treatment for diabetic ketoacidosis we give. Usually we have to give very slowly because sudden IV push can cause cardiac arrest. Next is your hydrocortisone. What is hydrocortisone? Someone tell me. What is hydrocortisone? చెప్పండి రా హైడ్రోకాట్ అంటే ఏంటి?
Steroid, ma'am.
Yeah, very good. So it is a corticosteroid. So tell me some clinical uses where we use corticosteroids. Tell me what are all the points we use corticosteroids?
Ma'am, pain, anti-inflammatory, analgesic.
ఓకే ఇంకా ఎందుకు ఇస్తాను రా మీ వాళ్ళు ఎవరికైనా ఇస్తావా పెయిన్ యాంటీ అనాల్జెసిక్ అని? స్టీరాయిడ్స్ అంత రెగ్యులర్ గా వాడతామా?
Erickson syndrome.
ఈనమా చెప్పండి, ఏదో ఒకటి చెప్పండి, నేను చెప్తాను కదా తర్వాత. ఏదో సిండ్రోమ్ అన్నారు, వినిపించలేదు నాకు. ఫర్ సపోజ్ ఎనఫైలాక్సిస్ వచ్చింది, ర్యాష్ వచ్చింది, ఫస్ట్ ఏం ఇస్తాం? యూజువల్లీ గివ్ స్టీరాయిడ్స్. We subside. Yeah, obviously it is an anti-inflammatory, but it is a steroid thing, so we don't prefer steroids. Why we got the drugs of non-steroidal anti-inflammatory drugs? Because of the potential complications of your steroids. They discard non-steroidal, so we won't give for fever and all those things. We give for serious anaphylactic reactions like anaphylaxis, we go with your steroids. So these are all the things. Acute severe asthma, we give steroids because of so that is nothing but aggravated inflammation, right? So acute severe asthma we give, anaphylaxis we give, hypoadrenalism like any Addison crisis where we are lacking of all these mineralocorticoids, glucocorticoids and all those things. Any suspicions of congenital adrenal hyperplasias we give, and in shock we give. So these are all the possible things, possible indications. So you just remember at least of 2, acute severe asthma and anaphylaxis. Usually the dose is, first we need to give like a loading dose like 10 mg per kg of loading dose followed by 5 mg per kg every 6th hourly. So these are all the things. What is ampicillin? Ampicillin ante entra?
Beta-lactam antibiotics.
Yeah, so ampicillin is an antibiotic. So which class of antibiotics ampicillin is your question? What is the dose in pneumonia treatment? If it produces a rash and a chill with fever, what are the possibilities? So these are all the expected questions. So it is a beta-lactam antibiotic, you already told, very well said. So semi-synthetic penicillin, the dose that is 50 mg per kg per dose 6th hourly. And usually ampicillin allergy or the patient may be having infectious mononucleosis, then also it will aggravate when we give your drug called ampicillin. What are the other things apart from your pneumonia where we give ampicillin?
In GE cases also, ma'am, gastroenteritis.
Okay, not like GE. Usually GE is mostly due to viral, so we'll not treat usually with antibiotics. Okay, and one more side effect with your ampicillin is your diarrhea. So that is not exactly the treatment. Okay. Previously, we used to give even for meningitis also. In neonates, we give neonatal septicemia. Mostly we give in newborns. The first drug of choice is your ampicillin. Why we are not giving nowadays? Because of your drug resistance. That's why we are not giving. Side effects usually include allergic rash that causes maybe having infectious mononucleosis or allergic rash, and one more potential side effect is your diarrhea. When you give orally, diarrhea will be there, but it is self-subsiding. There is nothing to worry. Usually we combine ampicillin with sulbactam, which is a beta lactamase inhibitor. So it also uses, so when you combine with your sulbactam, it is useful against infections caused by beta lactamase producing organisms. So next is your fluid ringer lactate. So where will we use ringer lactate? Same for volume expansion, along with you can use either normal saline or ringer lactate, but preferably we use ringer lactate when the child is not in severe decompensated shock, because liver is functioning. The lactate thing that is there, ringer lactate, it contains lactate 28, it will be converted to efficiently bicarbonate. So we'll use when the child is not decompensated. What are the constituents or components in ringer lactate? Is sodium 130 milliequivalents per liter, potassium is 4, calcium is 3, chloride is 109. If you observe carefully, see, normal potassium in our body is also 4. Sodium around 135 to 145. Chloride is also around 110. So this is almost close to your normal body composition. So this is best fluid or ideal fluid when the child is not in like any decompensated state. Like shock, it is acceptable to give. So it is a better volume expander, and because of resemblance to your close body fluid compositions. Next is your isolate P. So this is isolate P. Usually we use in neonates because it contains every electrolyte and all the things. So we need not add or subtract anything from that. So this is the pediatric maintenance fluid given when oral intake is not possible or when it is contraindicated. Usually, how will you calculate the formula for fluids? See, up to 10 kilos, we give fluid of 100 ml per kg per day. 11 to 20 kilos, we give first 100 ml per kg per day. So 1000 ml it will come, followed by 50 ml per kg for each kg of about 10 kilos. More than 20 kilos, for each kg, we'll add 20 ml per kg. So for suppose if the child is weighing around 25 kilos, first 10 kilos 1000 ml, next 10 kilos 500 ml, so plus 1500 ml, next 5 kilos 5 into 20 100 ml. So we have to calculate in that way. So 25 kilos, roughly 1600 ml of fluid is required for that day. That formula is called as holiday cigar formula. Another one more thing, normal saline, it contains sodium and chloride. Uses are same like in shock, in maintaining intravascular volume, and also better isotonic fluid. So sodium, it contains 154 milliequivalents per liter, as well as chloride, which is not close to your body composition. So whenever someone asked you to choose what is the best out of those two, you preferably go with your ringer lactate rather than your normal saline. Next is your cloxacillin. So it is also an antibiotic. So these are all the questions one can ask. What kind of penicillin is cloxacillin? What is specific indication to use cloxacillin in child with pneumonia? Can someone answer where we use cloxacillin in a child with pneumonia? Cloxacillin is effective against which organism?
Pseudomonas.
Inka, are you sure? Inka? So penicillin resistant penicillin, Staphylococcus pneumonia. So usually cloxacillin we use against Staphylococcus aureus. Okay. If you suspect staph pneumonia, that means if you are having any pneumatoseals on your X-ray, if you are having any empyema, you are having any long-standing thing, and when it is not subsiding, then we preferably add your cloxacillin. The dose is 15 mg per kg per dose, 6th hourly. What is diazepam? What is diazepam? It is a benzodiazepine. We use the dose of 0.3 mg per kg per dose. We use a rectal diazepam, IV, and all the modes are available. A risk for respiratory depression will be there, so it should be monitored. The rate of IV push should not be more than 4 mg per kg per minute. Uses in status epilepticus, febrile seizures. Even we can use this as an anxiolytic for sedation, and also as muscle relaxant, and as a pre-anesthetic medication. So parectally, the dose is the same, 0.3 mg per kg per dose. Usually we give through a flexible tube. Usually in status epilepticus, we prefer IV rectal diazepam. Drowsiness and sedation are side effects. Hypotension, respiratory depressions. Sometimes the rare side effect is ataxia. What is ceftriaxone? Which generation cephalosporin is? Yeah, which generation? See, it is a third generation cephalosporin. The generations are going up. It is more effective against gram-negative rather than gram-positive. So it is effective against gram-negative organisms, including your Pseudomonas aeruginosa and all the other things. So gram-negative, what are the things that are caused by your gram-negative organisms are like septicemias, meningitis. These are the potential things that can be caused. So third generation cephalosporins are used in meningitis, septicemias, and enteric fever. The dose will differ. Usually the dose for septicemia is 50 to 75 mg per kg per day. Meningitis 100 mg per kg per day. Enteric fever 75 mg per kg per day. So what are the possible side effects are allergic reactions, sludging of the bile, and also hypersensitivity reactions. Sometimes superinfections will be there sometimes it may be there, but not routinely. So cephalosporins indications are these like meningitis, septicemias, and enteric fever. What is digoxin? Digoxin ante ఏంట్రా? This is also seen used in congestive cardiac failure, supraventricular tachycardias, constrictive pericarditis. I already told you it is used in. It causes vomitings and cardiac arrhythmias. So this is also one of the inotropic drug, but because of its narrow therapeutic index, we are not using routinely. Shall I stop the class now? Shall I continue the rest of the drugs in the next class, or shall I continue? Shall I continue or shall I stop? Shall I tell the remaining drugs in your next class? So drugs are also like 2 classes. So these are the some of the drugs. The rest of the drugs, if you want me to continue for 5 to 10 more minutes, I'll continue, or else in the rest of the drugs will be dealing in your next class.
Next
Shall
class,
I start?
ma'am.
Yeah. So till now, so many drugs were covered. Just you write it down on the paper. So these are the completed drugs. So rest of the drugs I'll be discussing in the next class. So you can never expect only these are the things, but mostly only 95% these drugs only will be there in your examination. Just write it down. If any uncovered drugs are there, if you want me to teach you any other drugs, you suggest me, just write it down on the paper and put it in your group. So I'll tell those drugs even what are the drugs you want. So these are all the common things like fluids they will ask, antibiotics they will ask, some steroids they will ask, some inotropes they will ask, some bronchodilators they'll be asking. So these are the potential questions. That's why we are dealing randomly. If you want me to take some other drugs or some other drugs class, just what are the drugs you want, just you write it down on the paper and post it in your group. So I will be dealing in the next class with the rest of your drugs. Shall I